Well, go ahead. Without further ado, so I'm Caleb Corwin with the Center of Excellence here in Knoxville. Thanks for joining us for our July Learning Cafe. We are very fortunate today. We've got Dr. Ari Ravid. He is a clinical psychologist who works at, well, now he lives in Salt Lake City, but he's still treating patients out in Seattle. He is working. He did his graduate school training at Binghamton in New York, and then completed his internship at the Kennedy Krieger Institute at Johns Hopkins. He now works at the Evidence-Based Treatment Center of Seattle, treating children with anxiety disorders and obsessive compulsive disorder. He is a phenomenal clinician who is also involved in creating research and studying the benefits of treating children with anxiety disorders. And he's here today to talk to us about the importance of both assessing and addressing sleep concerns in children. So without further ado, here's Dr. Ari Ravid to talk to us today about sleep.
Thank you, Gil. Nice to meet you all. And thanks for having me here at your lunch hour. Feel free to eat or nap during the presentation, whatever would be best for your biology and overall well-being. I'm going to start my slides real quick. And feel free throughout the presentation to just ask questions. I don't think I'll be able to see the questions in the chat box, but feel free to either just interrupt or someone can tell me that there's questions, and I'd be happy to answer them. So yes, I work at the Evidence-Based Treatment Centers of Seattle. I work mostly with kids with anxiety and OCD. I've also had a long history of working with kids on the autism spectrum, kids with ADHD, kids with oppositional behavior. And across all of those settings, one of the main presenting problems that parents and caregivers and kids themselves come and present with is sleep-related problems. It was like the one constant across all my trainings and clinics that I've worked in. And so about 7 or 8 years ago, I got really interested in how do we help people with sleep-related problems? How do we help kids with sleep-related problems? And so that's what I'm going to talk about. In like the cruelest twist of fate, last night we were in the emergency room with my daughter till like 3 in the morning, and I got like 2 hours of sleep. So I feel this topic so strongly right now. And if I am having trouble with attention, please just, well, it's because I didn't sleep well. So my objectives for today are that we can describe at least 3 relations between sleep and DSM symptoms in kids. By the end of the talk, be able to identify at least 3 parameters of sleep that you want to be looking out for when you're assessing sleep, although I hope you identify even more than that. And I'm going to run through a few of the sleep interventions that I really like, although there are many more, and I have resources if you too find yourself wanting to study more about sleep. Okay, and if I had to be completely honest, what my real motive today is so nothing I say is going to be that surprising to people in this talk. You're all professionals. Even people who don't work as therapists, as clinicians, know the importance of sleep, right? Like we know it deep down in our bones. We have this knowledge, but I think very few of us actually believe that it's an important topic. And there's many things that I know but don't believe, right? Like for the longest time, I was drinking so much coffee, like 7 cups of coffee a day. And then just having these wild nightmares at night and like not being able to sleep. And like, I knew it was because of the coffee, but I didn't believe it. And so I didn't do anything about it. Only when certain conditions changed did I switch to decaf coffee. You know, my sleep's much better. And so we all know that sleep is important, right? It improves our memory. It improves our attention. Good sleep can help resolve difficult emotions. If you dream about a difficult experience that you have, you actually are more likely to resolve that experience in a positive way. Good sleep can mean that if you have a fight with your significant other, you're more likely to resolve that fight in a positive way. It can make you a better athlete. It can make you a better musician. I'm not just coming up with this. These are all research findings. Good sleep if nothing else, this is how I sell my teens on working on their sleep, is there's a study that shows that if you take a picture of the same person wearing the same clothes in the same background, and one picture is taken when they get less than 6 hours of sleep, and one picture is taken when they get more than 8 hours of sleep, without knowing why, a huge majority of people will find the person who got over 8 hours of sleep more attractive. And that is like, if I really want to sell my teenagers on getting more sleep, that's the stat that I'll pull out. We all know that sleep is really, really important. And very few, at least according to the research, very few of us clinicians target sleep-related problems in our kids. And so if I had one ulterior motive for today, it's to hopefully sway some people from knowing that sleep is important to deeply believing it in a way that we address it with our clients. So those were like just my ramblings on sleep and overall health and general wellness. But we do know that sleep and sleep-related problems are a transdiagnostic process for kids and for teens and for adults, actually, with DSM-5 symptoms, with clinical disorders. And these are stats that have been replicated over and over and over again. And I'll point you to some really good review articles if you want the exact specifics. But we know that for people with mood-related disorders, depression, depressive disorder, bipolar disorder, sleep is diagnostically implicated in those disorders, right? Kids have trouble falling asleep, staying asleep, waking before their alarm goes off and not being able to get back to sleep. For bipolar disorder, I mean, when people are in a manic episode, they sleep less often. But we actually know that sleep problems often precede a manic episode. And for mood disorders, one of the fastest ways to predict relapse for mood disorders is to start seeing sleep deteriorate. So sleep is highly related to these mood disorders. For anxiety disorders, for the kids that I work with, the stats are staggering. It's like 90% of kids and parents of kids will report at least one sleep-related problem. For kids with anxiety disorders, I think the other 10% are probably lying. I think it's just ubiquitous. I think that all kids with anxiety present with at least one sleep-related problem. In that we know that these problems are not just present when kids are anxious, but they are characteristic even when kids aren't anxious. They precede anxiety a lot of the times. Even when anxiety goes down, kids will report those sleep-related problems. Kids with ADHD also, it's very, very, and oppositional behavior, it's very ubiquitous to have sleep-related problems. So many parents of kids with ADHD will come in telling me that their biggest concern above and beyond school, above and beyond behavior, is that it's so hard to get their kids to sleep. Kids with trauma and trauma-related disorders, abuse, will report high degree of nightmares, trouble sleeping. Kids with all of these are related. Emotion dysregulation and suicidality, one of the biggest known risk factors for having suicidal plans and following through with suicidal gestures is to have a sleep-related problem. It's one of the most consistent findings. When I used to work in the autism world, when I was working with kids with developmental disorders, this again too, just like with ADHD, was probably either the first or second problem that caregivers would always come in saying was a problem. And then for thought disorders, with our kids, as they become adolescents, one of the first prodromal signs that we know can develop for developing a thought-related disorder is sleep-related problems. So I mean, all of that is to say, sleep is highly, highly implicated in all these disorders. And it's not just that it's a correlate, right? We know that for, like I was saying, for anxiety disorders, when the research shows that if you treat an anxiety disorder with the best evidence-based treatment, and you get kids to a place where they no longer meet diagnostic criteria for that anxiety disorder, sleep problems will go down, but persist sometimes at a clinical level, even after treating the anxiety disorder. like I was saying, one of the best ways to predict a future depressive episode or a manic episode is a preceding sleep-related problem. And so here there's some direct evidence that this is playing a role in developing those episodes. For each hour of sleep lost for kids and for teens, we see an 11% increase in the likelihood that they'll follow through with that they'll develop suicidal plans and that their suicidal plans will increase. And that is just a staggering statistic to me. Again, like we have so much trouble as a field predicting who is going to engage in suicidal behavior. We know it happens and happens frequently, but it's really hard to know what are the variables that predict it. And here we see a pretty robust variable. It is definitely in all my suicide risk assessments is to assess what's been happening with sleep. These studies are wild. They are some of my favorite. If you experimentally make kids sleep less, they will demonstrate hyperactive and impulsive symptoms, right? To the extent that they look like kids with ADHD. Showing a causal pathway between sleep-related problems. We think that it messes with, makes the striatum more overactive, makes kids more impulsive, have a difficult time inhibiting their impulsive behavior. Also, near and dear to my heart, this is research we were doing back in grad school, was that a large proportion of kids with OCD will have something called delayed sleep phase disorder, which we'll talk about in a little bit. But it's essentially where your sleep cycles are not aligned with societal expectations, kids going to sleep really, really late and wanting to sleep in. And that is a robust predictor that both medication and cognitive behavioral therapy will not be as effective in kids and adults with OCD. And lastly, if you can even identify sleep-related problems in kids as young as 3 or 4, that can predict like 10 years out, 11 years out, if they're going to be experiencing anxiety or depression or attention problems or even aggressive problems in adolescence. Okay, so I'm still just like hitting you over the head with stats. I realize that only works for some of us in terms of swaying us from knowing something to believing something, but I'm going to keep going just for a scooch because I think it's really important. Specifically to the populations that many of you work with, we know that kids who are in the foster care system have greater difficulty initiating sleep, have more nighttime activity, so are up more than other kids, and have more time in bed without falling asleep than matched peers who aren't in the foster system. One of the Dr. Tinanenko is actually my colleague at the Evidence-Based Treatment Center. When she was doing research in this with kids in the foster care system, one of her hypotheses was that they don't have caregivers there who are able to help them regulate fears at night, and so they're just more highly anxious and more worked up at nighttime. We know that shorter sleep durations for kids in the foster care system will produce a higher degree of ADHD symptoms, even compared to kids with ADHD who are not in the foster system. So sleep seems to play a really critical role in kids in the foster care system. Being placed in the foster care system earlier actually predicts that kids will have shorter sleep durations and more parasomnias, things like sleep terrors and night wakings and enuresis, things like that. Sleep problems are implicated in more difficulty with placement in a stable household. And in this recent paper, I think this is definitely a paper from 2021 or 2020, but I believe that Dr. Corwin gave a presentation, was that last month, on adverse childhood experiences on the ACEs, and there was just a paper that came out to show that sleep-related problems partially account for the link between ACEs and later oppositional and delinquency problems, is what they called it, in kids in the foster care system, and that sleep partially mediates that relationship, partially accounts for why those adverse childhood events will lead to more delinquency in later adolescence. And so sleep is important. I guess that's going to be my main theme over and over and over today. It would be too simplistic for me to say that that we think that sleep-related problems are the causal pathway leading to all these emotional and behavioral symptoms. What's probably happening is that it's just an unfortunate feedback loop, right? So having sleep-related problems makes these kids more sensitive to emotional cues, and adults more sensitive to emotional cues. I then either might have more ADHD symptoms, more anxiety, more mood related problems. That makes it harder to sleep, right? If I'm all worked up, if I have all this explosive energy, if I'm anxious, it makes it harder to sleep at night, and therefore makes me more likely to have emotional and behavioral problems the next day. And it can be even more complex than that. What we're starting to think is that, sleep related problems might make it, I'm just going to pick one of the behavioral problems, but maybe it makes me more irritable. I go to school, and because I'm more irritable, a teacher says something to me, and I just have more trouble inhibiting that irritable impulse, and I get in trouble. I yell at the teacher, I yell at other kids. I get suspended from school, I get sent to detention. Now I'm in trouble at home, and I'm all worked up because I'm in trouble at home. And that makes it harder to sleep at night. So it could be that sleep directly impacts behavioral symptoms, but it could be that the consequences of having emotional behavioral symptoms in the environment then sets the stage for my environment to pull for worse and worse sleep. So these things can be really, really complex. Okay, so those are my short run through for stats about sleep in clinical disorders. Again, I think many of us probably know this. We experience it deep down in ourselves. I also realized, I forgot to say this. I give talks on sleep all the time. Literally, I get yelled at more for this talk than any other talk that I give. And it's because it's so near and dear to all of us. One time I was giving a talk to a high school about sleep, and literally like the kids just started, I almost started a revolt. And then the kids just started peppering me about my own sleep and my own sleep related behavior. Like, this is super, super personal. So all of you know that this is an important topic. Should we pay clinical attention to it when there are so many other things going on, right? I might have a client, this is yesterday, just a random client who is coming with severe OCD, hasn't been to school in a year and a half, and is trying really hard not to go to residential treatment. There's suicidal ideation happening. Parents are incredibly distressed, right? And they sleep between 3 in the morning and 10 in the afternoon. Or no, 10 in the morning, 3 in the morning and 10 in the morning. And so with all of that, my clinical attention wants to say, like, let's treat your OCD. Let's get you back in school. Let's get you on medication if the doctor thinks that's appropriate, the medical doctor thinks that's appropriate. But with all that going on, I would make the pitch that yes, for that client, for many of these clients, we should still be paying attention to sleep and addressing sleep, even when there's other things going on. Because one, kids not sleeping affects how they're interacting with those around them. For instance, when kids need to be in the ER and only get home at 3 in the morning, their parents are also not sleeping until 3 in the morning and are much more irritable that day and less able to implement. This is myself. I'm talking about myself. Much less able to implement the really hard interventions that we need them to implement, right? And so same thing with school, same thing for caregivers. Difficult sleep impacts the whole system and makes it less likely that all my other interventions are going to work. That's been shown across different interventions. Even when our interventions do work, if sleep is still a major factor, if we haven't addressed sleep, it is a huge predictor that kids are going to relapse. And I can't tell you how, you all know how discouraged a lot of these kids are if, and teens and adults, if they've put in an enormous amount of work, they've no longer meet criteria for their presenting problems. And then a month later, 2 months later, 6 months later, those symptoms come back. They are really devastated. Usually we're able to help, but if sleep related problems are there, it can be quite devastating if there's a relapse. And sleep is such a transdiagnostic factor. I would point you to an article by Allison Harvey from like 2014 and 2015 that if you, and I think it's in the references in the slides, if you can treat sleep-related problems, you might see decreases in symptoms across a broad range of comorbidities, right? You're getting so much bang for your buck if you can treat sleep-related problems, and all of a sudden you see anxiety go down, mood improve, behavioral problems at school abate. And so I do believe that we should treat these sleep-related problems even when there's so much else going on. So some of us are swayed by statistics. I know I am, but some of us need to feel it on a deep emotional level. We've also hit about 20 minutes into the presentation, and I know that's when attention starts to fade. So for those of us who need a little bit of emotional evidence that sleep is important, I present you with this. It might be impossible to look at this dog and not know just how important sleep is for all of us. So that's it. I just actually want to give us all a break because hearing me talk for more than 20 minutes is not something I would wish on anyone. Oh, this dog. All right. Questions about sleep in clinical populations before we move on to what are the common symptom or sleep-related problems and how to assess them and treat them? No. Okay. Nothing in the chat. Cool. Okay. So common sleep-related problems, and this is in all kids, but it's exacerbated again in kids in clinical populations. One of the most common sleep-related problems is something we call behavioral insomnia of childhood. And this takes two different forms. It can be a sleep onset association. So that is when kids have trouble falling asleep or staying asleep throughout the night if certain conditions aren't met, right? My daughter had this early on, right? She would only fall asleep if one of us was in the room with her, if she was sleeping on top of us, if she woke up in the middle of the night and we weren't there, she would start crying and lose her mind. And yeah, so that is, that's considered a sleep onset association. Not all sleep onset associations are bad. It just depends how it's functioning, right? So for me, that was a tough sleep onset association because, and for my clients, right, like they are often sleeping with their kids till they're 11, 12 years old, not getting any quality time with their significant others. But for some people, a sleep onset association is great. We have one for our daughter right now. I sing her the same song every single night, and I give her a kiss on the head, and I say, "Good night, I love you," and then I throw her in her bed, and she falls right asleep. That sleep onset association with the song is just fine for us as a family. There's also a limit setting type. So this is where you see kids refusing bedtimes, like bedtime refusal, you know, a lot of tantrums right before bed, waking in the middle of the night, and again, refusing to go back to sleep, not even with parents present. That would be, and also falling into that category is if parents have trouble or caregivers have trouble setting limits. So sometimes kids are going to bed at 1 in the morning, sometimes they're going to bed at 11 at night. They're kind of just free range, I guess. I don't know how else to put it, but kids are, there's troubles with limits. Another significant number of kids, again, this is for basic biological reasons, especially in adolescence, many kids will meet criteria for a delayed sleep phase disorder. That's when kids have difficulty falling asleep and staying asleep at socially acceptable times. This is like a disorder of modernity in my head, in that it isn't intrinsically bad that kids have a biological need to sleep later and wake up later than other kids, right? So this would be The definition for delayed sleep phase is falling asleep at least 2 hours past what's developmentally appropriate for them. So that would be, if my daughter's supposed to be asleep at 8 for her age, if she only goes to sleep at 10 or later, and it's not due to cultural norms, then that would be delayed sleep phase. The problem with this one is school start times are set. They're not set based on people's circadian rhythms. They're set based on regulations and laws. And so for kids with delayed sleep phase disorder, they're often getting very short sleep durations, and that can be problematic. Parasomnias are waking in the middle of the night, sleepwalking, sleep terrors, so yelling in the middle of the night without kids actually remembering that they're yelling. Confusional arousal. This seems like kids are awake, they're talking, but all of a sudden you're talking to them and you realize they're not even awake at all. They're telling you about how a dog was in their room sniffing them, and they're at the fridge drinking milk, and you're like, oh, actually you're not even awake, and you just guide them back to bed. Nightmares are incredibly common in kids. They're not inherently problematic, but for up to 50%, the nightmares are so problematic that they're keeping them up. Kids are refusing to go to bed because they're scared of nightmares. And there are breathing sleep-related problems. And these are just common sleep-related problems. There are definitely there's periodic limb movement sleep disorders, like restless leg syndrome and stuff like that. So these are the common ones you're going to want to look out for. When I'm going to be talking for the rest of the time about assessing and treating sleep-related problems. Know that I'm doing that, talking about behavioral sleep-related problems. I'm not a medical doctor. I always send my clients to a medical doctor just to make sure we're getting a thorough assessment of any other medical conditions that could be leading to sleep-related problems. But today I'm just going to be talking about behavioral sleep problems. So my goal is to start assessing my clients' sleep and sleep-related problems. And before even starting to ask them about what their sleep is like, how much did they sleep, how the quality of it, I want to start knowing some things about their sleep environment. And I take a lot of this from this really, really stellar article that if there's just one article you want to read and just be super pumped, I would read this article right here, the Pediatric Sleep Health. It came out, I think this year, if not last year. And especially Dr. Williamson is just brilliant at contextualizing sleep and how it works on so many different levels of operation. So one of the things we want to know are the social determinants of health and how that might be impacting kids' sleep. So do they have access to green spaces, lights? Do they have inappropriate access to lights? Is there light on at night? Is it a noisy environment? Things like socioeconomic status. Who else is in the room? Are kids exposed to toxins or allergens? Is there a lot of community violence and things like discrimination? Are kids experiencing discrimination? Are they perceiving that they're experiencing discrimination? All of these can really impact sleep. We want to know about kids' medical status. Again, sometimes certain sleep disorders are indicative of medical problems. Periodic limb movement disorders are classically, but not always, related to a deficiency in iron. Pain is related to sleep problems. I want to know kids' medical status before we start on this for sure, because it might lead to a different intervention. What are kids' nighttime routines, but also what are their daytime routines? Are they exposed to bright light early in the morning? That is really beneficial for sleep. Are they exposed to bright light late at night? That is really not beneficial for sleep. Are they moving? Do they have consistent wake times, consistent bed times? Those are all implicated in how we would want to develop treatment. What is the sleep environment? Who's in the room with them? Is it noisy? Is it dark? Are there electronics present? Those type of things. So I'm going to be starting to ask about all these factors before I even start asking about kids' sleep. And then when I'm ready to, so for the longest time when I was asking kids about their sleep, I have sleep tracking forms that I'll show you, but I was just kind of doing my very, very best to ask all the questions I could think about sleep. And then after reading this article, it gave a great acronym that I've stolen and taken as my own now, not in a copyright way, but just in my clinical practice. And it is this acronym of be sated, and it stands for sleep behavior, sleep satisfaction, how alert kids are during the day, how efficient they are at sleep, and how long they're sleeping, the duration. And I'll go over every one of these. But now I write this acronym down before I go into my sessions, before I go into my intakes, and before I go into my sessions, so that I remember to ask about each aspect of sleep, because each aspect of sleep is sometimes uniquely related to different aspects of health and wellness. All right. So in terms of sleep-related behaviors, these are the behaviors that can definitely impact sleep, or either promoting wakefulness or tiredness. So caffeine intake, I didn't used to ask about caffeine that much. And then I read a study that says by elementary school, somewhere between 25 and 50% of kids are drinking caffeine on a regular basis, usually from soda. And for their little bodies, that could 100% impact both their ability to sleep. And even if it's not impacting their ability to initiate sleep, it could be impacting what their sleep looks like, their sleep architecture at night. And so I always ask about caffeine intake now, how many Red Bulls they're drinking, or 5-hour energies, or I don't know, whatever the kids are. I'm not cool enough to know what kids are drinking these days. I ask, so other behaviors is regularity of their schedule and routines. So this is both like during the day, like I was talking about, but it's also, do kids have a consistent bedtime, and do they have a consistent wake time? That can really impact their ability to sleep. So there's this thing called social jet lag in the sleep research. And that is when kids are going to sleep an hour or later on the weekends compared to the weekdays. And it's essentially what it sounds like. You're putting yourself in a different time zone. My kids in Seattle are putting themselves in my Utah time zone now, or maybe even in the Tennessee time zone, by sleeping 2 or 3 hours later than they do on the weekdays. And I can't tell you, once I start taking data from kids, how often their worst sleep problems happen on Sunday nights and Monday mornings. And it is invariably because, the data will show, oh, I slept until noon on Sunday because I could. And then I tried to go to sleep because it's a school night. I tried to go to sleep at 9 p.m. because I know I need to get good sleep, but they've only been up for 9 hours. That's not enough time to build up a sleep debt in order to be able to fall asleep. And so Sunday night, Monday mornings are invariably a very difficult time for many of the kids I'm working with. I ask about, are there any sleep onset associations, things that need to be present in a specific way? For my kids with anxiety, a lot of times this might look like, especially for my kids who I work with OCD, parents have to say a specific thing in a specific way at the right time at night, give them 2 hugs and turn off the light and then go to bed. And if that's not present, then they need to start all over again. Are there any associations that are impacting the ability to sleep? And then electronics. This is one we all know as well. Like everyone hears this, everyone preaches it. But these are just 2 stats that I use for the kids. So we all know you're not supposed to have access to electronics. Bright light messes with your circadian rhythms an hour before bed. You really want to dim those lights and not have access to bright lights, especially from handheld devices. But I read an article that said that right now, this was in 2019, about 33% of teens say they wake up multiple times a week to check their social media, multiple times a night to check their social media, see if anyone's DMing them, see if they're getting blasted on. There's a hate page on Instagram or anything about that. They will wake up multiple times a night to check their social media if they have access to a phone. And then another study that I'll tell my clients is that there is this study that if you have an electronic device in your bedroom, even if it's in airplane mode and it's close to you at night, even if you don't get any messages, even if it doesn't go off one single time, it can affect your sleep architecture compared to people who, like what your sleep looks like at night, compared to people who don't have any sleep related problems. Who don't have devices in their room. And so kids will tell me, I never check it. I put it on airplane mode, and it's not their fault. It's just like a Pavlovian association we have by checking our phones all day. It can mess with the quality of your sleep just by having a device present. This one took me literally like a year and a half of effort on my own part to get my phone out of my room. The simplest thing that everyone will say is like, my phone is my alarm clock. So I like send them to the 99-cent store to get a watch that, like a really dumb watch that has an alarm on it, and we just fix that problem. But I can't tell you how often this is a problem. So, okay, behaviors, sleep-related behaviors. The next variable is just satisfaction. This is the hardest one to objectively define. It is incredibly subjective. It's just, how do people perceive their sleep as the last night? How do kids perceive their sleep was the night before? That's the pure definition. It rarely aligns with what objective measures of sleep will say, right? Like if you put a, we call them actigraphs, or like just a sleep monitor, a physiological sleep monitor on people, satisfaction almost never aligns with what their physiological sleep monitor says. But it is unbelievably predictive of health and well-being, right? Just someone's subjective satisfaction. We then ask about daytime alertness, like are you napping during the day, napping inappropriately napping. When kids are little, they have, when they're very little, they have wild sleep patterns, but when they're like my daughter's age, toddlers and young children, they have something we call biphasic sleep phases, where they get most of their sleep at night, but they're supposed to sleep during the day, they're supposed to take naps. Then by the time you get to elementary school and middle school especially, that usually is supposed to all be consolidated at night. So if kids are still sleeping during the day and it's not a cultural norm, an expectation, then that could be really an indicator that they're getting poor sleep. For my daughter and for my dog, actually, if they are overly tired or getting poor sleep, it might not look like their alertness is flagging. It might not look like it's down. It actually, we call it the zoomies in our household. They just like run around the house and they'll jump on the sofa and they'll, start getting, both of them will get really irritable. And so poor alertness might not look like it does for adults, where we just say, I'm really drowsy. It might actually look like people are overtired. It might just look like they're irritable and have a ton of energy. Okay, so behaviors, satisfaction, alertness. When is the sleep happening throughout the day is also an incredibly important. So what time did you go to sleep? What time did you stay asleep is another question that I'll often ask. Kids and teens especially, will say it doesn't matter when I sleep as long as I get 9 hours of sleep, but that is actually not always true. And the way that I make this point, you can steal this if you want, as I say, like, if you got 9 hours of sleep, but you slept for 1 hour at 10 a.m., 1 hour at 12 p.m., 1 hour at 2 p.m., 1 hour at 4 p.m., and you did that all throughout the day, and that's how you got your 9 hours of sleep, no one would say that's quality good sleep, right? And so then from that extreme, we can work back to saying, actually, you want your sleep to happen at a very specific time. For young kids, you actually want, the research shows that they want to be asleep somewhere between 7:30 and 8:30 at night. Again, unless there are cultural norms dictating that that's different. Some cultures either will sleep earlier or later and have a nap built into the culture. You really want kids sleeping somewhere between 7:30 and 8:30 at night. Then I ask about it, sleep efficiency. Sleep efficiency is essentially how long are you in bed compared to how long are you sleeping in bed. How long are you in bed trying to sleep compared to how long are you in bed sleeping. A high sleep efficiency number, like 100%, you're supposed to multiply this by 100%, will indicate that you are pretty much sleeping in bed, or the entire time you're in bed, you're pretty much sleeping in bed. Lower sleep efficiency numbers will mean that you're spending a lot of time in bed. You might get 8 hours of sleep, but actually I'm trying to sleep for like 2 hours before that, and I'm super frustrated just lying in bed. I also am awake and trying to go back to sleep, but I just can't. And so sleep efficiency is another factor that I always ask about, and that will be implicated in some of the interventions we talk about in a little bit. What you're ideally looking for is a sleep efficiency over 85%. That's supposed to be good health, although better to be higher. But all of us on average, I'll tell kids, just so they know, the average time to fall asleep is about 20 minutes. So if kids are taking like 20 minutes to fall asleep, I think that's just fine, if they're awake trying to fall asleep. All of us wake up like 4 times a night. Some of us just don't remember it. It takes adults like 4 minutes of being awake at night to even remember that they were awake on average. That's on average. So again, if kids are awake for a little bit in the middle of the night because they woke up, that is just fine as well. But you want to have a high sleep efficiency. And lastly, I will ask about sleep duration. This is the one that we all typically will ask about, but how many hours of sleep? This just comes from the CDC's website. How many hours of sleep did you get? And that's usually about what we're shooting for most kids. Some staggering number of us, kids and adults, do not meet these guidelines. It is like, I think, I don't want to be misquoted, but it is a majority of people are not meeting these sleep recommendations. But that doesn't mean it's okay. Okay, so those are the different factors. I'm going to be assessing the environmental determinants of sleep, medical factors, and then I'm going to be asking about that. And I try to get at this information in a few different ways. I'll give a sleep diary. The one I'm using here is the Consensus Sleep Diary that was put out in, I think, the mid-2000s by just a group of experts in sleep, saying like, and you can just look that up online. It's freely available. If you just look up Consensus Sleep Diary and have kids track this over time. I might have them track it in an app. I'll have them track it in a notes, although not if the phone is in their bedroom at night. I also will give them sleep questionnaires. There's a few different sleep questionnaires that I like that I can share if anyone's interested. I'll ask child for their report. I'll ask parents or caregivers. There's even in the applied behavioral analysis world, someone just put out a whole paper about how to directly observe sleep and accurately code how much and when people are sleeping. I don't think many of my clients would like me sitting in the corner of their room while they sleep, directly observing it, but it is possible. And then there's these wearables, right? Like I have an Apple Watch. Not everyone has that, but like it does do a pretty accurate job at capturing sleep. The correlation between all these factors is really, really low, right? Like the correlation between child and parent or caregiver report of sleep is really, really low. And then there's formal sleep assessments, right? Like going to a sleep lab, sleeping in a sleep lab, hooked up to a bunch of different monitors. The correlation between all these is usually quite low, but that's okay. That's just why I want a multi-method assessment, so I can have a pretty robust understanding as a clinician. What does sleep probably look like? Okay, so we've got, so sometimes that assessment is enough, right? Like we don't even have to go to formal treatment. If I did the assessment and found out that that kids are drinking like Red Bull at like 5 p.m, like I don't really have to start thinking about formal sleep interventions right away. I just need to knock the Red Bull out of their hands or something like that, right? Our assessment can often lead to just a very straightforward problem-solving intervention to improve kids' sleep. But sometimes it doesn't. And there are formal sleep interventions. I love all of these sleep interventions. They're my favorites. I underlined 3 that I'm going to talk about, but they're all wonderful and great. And there's books, especially, I'll point out one book that I think is wonderful that was put out by American Psychological Association that has a review of all these interventions, how to do them. But I'm going to review parental caregiver education, the Bedtime Pass procedure, and cognitive behavioral therapy or cognitive behavioral treatment, I should say, for insomnia. So parental care and caregiver education is part of any sleep intervention. Just really, giving this talk that I just gave, but in a shorter form with less jokes, maybe more jokes, to parents, talking about how much sleep kids need, about what the variables are that are important for sleep, about setting consistent routines. And again, that's daytime routines, nighttime routines, inconsistent bedtimes and wake times. how to optimize the sleep environment as best as possible, fully acknowledging that there are some really hard challenges in making this work. And I just want to be there with my clients, helping them. Like none of this, I never want this to come across as blamey in any way, shape, or form. And again, I will self-disclose all the sleep-related problems we're having with our daughter, all the sleep-related problems I've had throughout my life, right? Like I want parents to know that I'm here with them, helping them with this rather than blaming them for poor sleep. But I also want to impress with the heat of 1,000 suns how important sleep-related problems are. And I do that not only by trying to just say it, because again, we all know it, but I ask about sleep in my intake. I ask about it in the first session, in the second session, in the third session, in the fourth session, until people are so annoyed with me about asking sleep. But when I have them consistently track it, it does impress just how important this variable is to them. I will also really be there to listen to my clients about what their cultural norms are, what their personal norms are around sleep, and how we can help those mesh with the real biological sleep needs for their kids and discuss their deep ambivalence, right? So like many clients I have will say like, well, I know that if I do a sleep intervention, we're gonna have to do cry it out, or we're gonna have to do something called extinction. And it is finals next week. And if we have to do that, they're gonna get terrible grades. Or I have a big work presentation next week. Maybe I have to give a presentation on sleep. And if we're up all week, I'm gonna be terrible at this presentation. And so they're not ready to do this intervention. And really deeply discussing the ambivalence around making sleep changes in a way that we can then move them towards a process of being willing to make some changes. Okay, so we've given education. This is clearly just a plug for someone to read my article. I didn't, just kidding. We published an article on this, but this is a procedure that's been around for like 20 years. Using bedtime passes to help kids who are co-sleeping with their parents, in co-sleeping in a problematic way. I want to make it clear that I don't think co-sleeping in and of itself is a sleep-related problem. If it's not a problem for the kids, and it's not a problem for the adults, right? But for many kids that I work with, they're like, I don't want to sleep with my parents anymore, and the parents desperately don't want to sleep with their kids anymore. And it is some type of emotional problem that's driving this. Then we'll implement the bedtime pass procedure. And what this looks like, feel free to read the article. I think it does a good job of describing it, is we take baseline measurement on either how often kids are coming into a bedroom for attention at night, or if parents were to start having kids sleep on their own, how often they come back into parents' bedroom or caregiver's bedroom. And then what we say is, okay, we are going to give you, this is just a sleep pass that I used with a client, but we're going to give you these, I laminate them and sign them on the back so kids can't, counterfeit my sleep passes. But what we say is, okay, you are a really big kid. I'm so proud of you. It's time to sleep on your own. If you need us as parents, as caregivers at night, all you have to do is come and turn in a bedtime pass. Sometimes we'll start with 1 or 2 bedtime passes for all kids. Sometimes, depending on the severity of their sleep problems, I'll give them more based on their baseline data. They get a replenishing amount each night. And all they have to do to get attention, to get hugs, to get kisses, to talk about their fears at night is come give their parents a bedtime pass. And then once they give the parents a bedtime pass, they get 5 to 10 minutes of really high quality attention from their parents. And at the end of those 5 or 10 minutes, you walk the kid back to bed, tell them you love them, and have a good night. And once kids are out of bedtime passes, that's when something called extinction happens. That's when parents no longer give attention. They just walk their kids back to the room and have them and keep doing that over and over the course of the night. And then in some procedures, in the ones I do, we also include a reward for keeping a bedtime pass over the course of the night. So say you started with 2 bedtime passes, but you only came and got me once. You still have a sleep pass. I've had kids earn strawberry deliciousness for breakfast. I have them like a delicious breakfast versus like a boring Cheerios breakfast. Sometimes I have kids earn a little bit of extra screen time in the mornings, whatever we think can be a reinforcer for keeping a bedtime pass. And then over time, you fade out how many bedtime passes kids have. Sometimes I leave kids with 1 because, they vomit or whatever happens at night. They have a pass to come get their parents. Then there's cognitive behavioral treatment for insomnia. This has been mostly studied in adults, but there is starting to be a robust literature showing CBTI can work for adolescents. So you probably wouldn't be doing CBTI for children, but for adolescents, you could. And what CBTI is you give psychoeducation on sleep, on how sleep works, on circadian rhythms, on the sleep drive. And then there is a behavioral component to CBTI, and that's called stimulus control or sleep restriction therapy. Stimulus control is saying essentially teaching people that your bed is only for sleep. For adults, we say it's only for sleep or sex. For kids, I usually just say it's for sleep. And for nothing else. You want your bedroom really to be a robust predictor of producing hormones that promote sleepiness, like melatonin. So nothing happens in the bed other than sleep. If you're in your bed for longer than 30 minutes, you get out of your bed and only get back in bed when you're tired, because you want that bed to be such a strong cue for sleepiness. And then sleep restriction therapy is kind of what it sounds like. So this is the hard push, but it's worth it. So you take baseline data on when people are actually falling asleep. So they might get in bed at 10, but only fall asleep at 2 and wake up at 7 or 8 each day, 6. And then what we do in a very thoughtful way is tell people, okay, you've only been falling asleep successfully at 2. I want you to only get in bed at 2, and you still are going to wake up at a very consistent time the same day. People will usually flip out, understandably. They'll say, you're telling me I'm not going to be able to go, I'm only getting 5 hours of sleep. And it's true, but they're already only getting 5 hours of sleep because we're taking the average of when they are successfully falling asleep. And then once they have a high sleep efficiency score, we then fade back to more, well, you can either fade forward or fade back. There's some nuance there, but you fade to getting more and more sleep with higher and higher efficiency. And then there's a cognitive component that involves, so many of my clients will say, like, I'm really scared to that I won't get a good night's sleep. They start getting in bed, they start freaking out that they're not going to get sleep, that they're going to have a terrible day tomorrow, that they're going to have nightmares. And we use cognitive strategies to help them come up with more balanced thoughts that help them promote sleepiness. Perfectly, right on time. I want to make sure we end early. So, okay, my summary is, like, sleep is really important. Sleep is really, 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 really important. I hope we all believe that now, at least some of us. There are ways to assess sleep in a multifaceted way, and interventions can really help. I have a bunch of, the Pediatric Sleep Problems book is the one I really, really like. It just outlines all the behavioral sleep interventions for kids. These are all great books. They're just hot reads. You have a summer day, you don't have anything to do, just like really pop open one of these books. You're going to be doing great. And then some websites that can be helpful. University of Pennsylvania, if you really want to do CBTI training, they are great. Dr. Craig Kinapari is the director of the Yale Child Study Center's sleep department, and he has a very, very accessible website for both clinicians and parents. And one of the books I recommended was his. That is it. You have access to all these, so please feel free to look through any of them, and please feel free to email me if you have any questions or just want to yell at me or whatever. That is fine. I'm happy to hear from everyone.
Does anybody have any questions while we still have Dr. Ravid here? We've got a couple minutes. You can type them in the chat or just unmute yourself.
All right, so I'm going to go ahead with a question then. So I've got one of those nifty Fitbit trackers.
Oh, yeah.
And so it's giving me much more detail about my sleep. And so if I go to bed at, say, 11 o'clock and wake up at 7 o'clock, I think to myself, oh, I got 8 hours of sleep. And I pull up that stinking app and it says, no, you got 7 hours and 15 minutes of sleep. So when we're talking about you need 8 hours, or we need to make sure you get 8 hours, are we talking about what my Fitbit actually says I got, or when I fell asleep and when I woke up?
Yeah, so what I will say is I stole this from Dr. Kanapari. He will say, you want an 8-hour sleep opportunity, right? Give yourself an 8-hour sleep opportunity. Now, if you're because this can, I love my sleep app. The Fitbits are okay as a sleep monitor, just so you know that they're not great. It can really promote some anxiety in my clients, right? And in me, if I'm saying like, I think I got a good night's sleep, but my watch is saying I got a terrible night's sleep. And again, your subjective sense of sleep is really, really important too. So the way I put it is like, if you're feeling good and you gave yourself a great 7 to 8 hour sleep opportunity, you're in a really good spot, right?
Okay.
And I wouldn't worry too much what your watch says. The watches are more helpful. Actually, there's this thing called paradoxical insomnia, where people are actually sleeping 8 hours, 7 or 8 hours, but their brains are telling them they only slept like 3 or 4 hours. And they're very distressed. And sometimes the sleep measurement can be really helpful then to say like, actually, you got a pretty good night's sleep last night. And that can be really helpful.
Good to know. Thank you.
Thank you.
Well,
everyone's asleep probably. That'd be my guess, which would be great. I would have done my job.
I hope everybody will join me in thanking Dr. Ravid for coming and presenting to us. This is so helpful, and I think so incredibly important for all of the kids we're serving. Just sleep is critical for everybody, and we don't address it enough. So thank you so much for coming and talking to us about this and trying to help the kids we work with. I want to remind everybody that there is a link to the slides, a copy of the slides in the chat. There's also a link to complete the survey in the chat. If everybody will take a minute to click that link and complete the survey, then you'll be emailed your certificate of participation for today. And I want to remind everybody that next month on August 20th, our presentation will be by Beth Smith from Tennessee STEP, presenting to us on education advocacy for children with disabilities, how to use the 6 principles of IDEA to receive services and make progress. So thank you all for joining us today, and hope to see many of you all next month.